To our guest lines now, where Dr. Steve Martin joins us in a sports medicine segment brought to my great friends over at Arthrex, the orthopedic surgeon, Blue Ridge Orthopedics, Prisma Health, and head orthopedic surgeon for Clemson University Athletics. Dr. Steve Martin joins us now. Good morning, Dr. Martin. How you doing?
Good morning, Mickey. I'm doing awesome. How about you?
Man, great. I knew you were awesome because even if you're not, you feel that way. And I love one of the traits of lucky people is they think they're lucky. And one of the traits of people who are in a good mood is they think today is great, and they're blessed with that. So that's awesome. I wanted to ask you about one of the most interesting articles that I've seen, and I read this on someone sent this to me from NBA.com about Lonzo Ball, the Bulls player that had knee cartilage donated to him, and in a transplant. We've seen, doctor, these heart transplant where the family finally gets to meet the recipient. We've seen eyes and things like that, these life-saving and these life-changing things. I had no idea until I read this article. We have cartilage transplants and people who are donating cartilage. I had no idea this was happening this way. I'll get your thoughts on this information. Like, what does it mean to have cartilage transplant?
Well, on this specific, story, I think that, on one side of that equation, you have, human tragedy, you have, human just tremendous sadness, when you have a loss of life, especially at an early age. And for those of you, when you're checking on your license plate, whether to be a donor or not, just think about the amount of goodness that can come from that event, if that were required. Obviously, it's hard to think about, and the sadness is tremendous on one side. But yes, we have tissue in the body can be transplanted. Obviously, we know about hearts and livers and kidneys and eyes and the lens of the, all the other tissue that can be transplanted. But we do a good bit of it's called an allograft. In this case, osteochondral allograft. Osteo means bone, and chondral means cartilage, and so you have, a portion of the bone and cartilage from a donor. In this case, is kept fresh because those cells have to be kept alive, and they can be transplanted. In this case, from one knee to another knee. In addition, you can have the meniscus tissue. We've talked about that as well. And so, the problem that arises in the athletes, especially the professional level athletes, is they've been beating their joints up for a longer period of time, and they will develop damage and irreparable damage that can be career-ending to the cartilage of the knee, in this case, cartilage and meniscus of the knee. And was unable to return to play because of that. And so he received a fresh meaning within a certain period of time, osteochondral allograft from a donor, and included a meniscal transplant to his knee. And then the family was able to connect with him, which you take that tremendous sadness, and on the other end of that equation, you have, the happiness of all the lives that have been positively affected by that. In this case, an NBA player, and so it's just a tremendous story. I think it's brings out tremendous emotion, both ways. But I think it's and the science of it is. It's still growing. We've used, analogies. You say, well, why don't you just do a knee replacement? Well, a knee replacement doesn't work in a, 24-year-old or however old, professional athlete that's pounding on a basketball court. And so you've got to try to, keep these joints going, for 25, 30 years. And so this ability to, put cartilage and bone back in the knee and meniscus tissue back in the knee and have it survive and keep that knee going, not only for return to play, but to be honest with you, just for the next 20 to 30 years of life. And so it's a tremendous technique.
We know, obviously, matching, are you a match for this? Are you a match for that? Is that happen too? Or there's criteria for matches for cartilage for this kind of?
Well, it's a little. Yeah, not to go too much into the science of it, but tissue, all of our tissues in our body are they're labeled. So our body knows that it's our tissue, right? And so if you have tissue from somebody else, our body's going to say, hey, that's not me. I'm going to get rid of it. And so you have to have on most tissues that have what we call antigens. Antigens are that label. It's a mark on that tissue that says who it is and who will accept it. And that's called HLA antigens, human leukocyte or human white blood cell antigens. And you also have a blood type. Everybody knows, or you're a B plus, or you're O plus or O minus or whatever. Your blood type. And so that's for the same reason. If you were to receive somebody else's blood, it needs to be as close to yours, or your body would have some kind of rejection. Your immune system wouldn't like it. But with cartilage tissue, cartilage is what we call immune privileged. Immune privileged means it doesn't have those antigens. And so the cartilage doesn't cause a reaction. Now, the bone underneath of the cartilage, this is a piece of bone and cartilage together. The bone underneath does have some immune response, but it is usually, in most cases, fairly limited, and we don't have to have the specific matching from that standpoint. But we do have to match size and shape. In other words, I can't, put a big piece of cartilage and bone if it's not smooth. Think of the road out there. We talk about the pothole in the road. And if I'm going to plug it with something, I can't have the piece going into that hole bigger than what the hole is, or a different shape. Otherwise, you've not really created a smooth surface. And so it has to match, and that's where the surgical technique of matching, a right femur to a right femur and a medial side inside of the right femur to the inside of the right femur, and then cutting it and shaping it and then plugging it in such a way that it fits tightly, and then will become the new patient's bone and cartilage.
This might be the dumbest one in a long list of ones, but the donor in Lonzo Ball's case was 20 years old.
Correct.
How important is that compared to, is there an age where we wouldn't be a donor? We would donate other parts of the body, obviously, but you might not be eligible, or you wouldn't be considered as a donor?
Well, the viability and the health of the donor tissue is very, very important. And so cartilage and bone in a fresh state is only going to live so long. And so the clock is ticking. And so the younger and the healthier that tissue is, the better it's going to be, right? Nobody's going to want my 65-year-old knee cartilage because it's already worn down anyway. And so when I specifically ask for a allograft, that's a tissue from another patient, I'm asking for under age 40 and a non-smoker, right? In other words, we don't want somebody that was smoking because that tissue is not as viable, and I want somebody that's under 40 because that tissue is going to be healthier. And so, yes, there are some specific age criteria, and once you have a kind of a time clock once that happens, and so the availability of tissue sometimes is limited, and so that's why the importance of if you are going to check that box, I encourage you to, I know it's a difficult thing to think about, but I would encourage you to check that box, for the young listeners that are out there, because I think it can be a very valuable thing.
I was sent this. I have no idea what this means. I can't wait for this answer. How is this procedure different than using donor grafts to reconstruct an ACL tear?
It has to do with tissue. I guess I'm thinking out loud here, so take my answer for what it's worth, but I can take tissue for, let's say, a allograft, a cadaver, patella tendon, and I can preserve it in such a way that it can have a longer shelf life before it's put in and still be viable. The biggest difference with the osteochondral, especially the cartilage portion of this, is you only have a certain number of days where the cells are still going to have enough viability to be worth transplanted into another patient. Now, we've had some techniques in the last 5 years that have extended. It used to be 28 to 30 days, and now we have 60, 65 days where the tissue viability has still enough that you can get by with it. But you have a timeline between donor and implantation with the osteochondral graft that you don't have with some of our soft tissue grafts that we use for ligaments.
All right. Is this a unique situation? Have we done this in the past? Will this become more common with elite athletes choosing this? And does the everyday person need to consider, the average non-athlete, would they consider this?
Well, it is not rare. We're seeing it, unfortunately, when you look at the arthritis rate in all of these NFL and NBA and other athletes, in their 30s and 40s, it's way too high. Just like other parts of the body, these joints are getting beat up at a rate. And it's not just the athletes. We see it in all walks of life. And so what do you do for the 25-year-old or the 32-year-old with these cartilage defects in their knee? And so it depends upon the size. As the size is, basically break it down into dime size, nickel size, quarter size, $50 size, right? Think of those pothole sizes in the knee. And so for a dime size lesion or smaller, it can have very minimal amount of surgery. As you get to nickel and quarter, you can fill the pothole with other types of grafting procedures, even from the same patient. You can take bone and cartilage from one part of the knee and put it in that area that is more critical in terms of weight bearing, but you're limited, right? You can only take so much of a size of a graft because where you take it from now doesn't have bone and cartilage, right? And so you're limited to those, nickel and quarter size lesions that you can take from the patient's own joints and move over to a different area. As you get a bigger than a quarter size, now you've got to do, in this case, a transplant type situation. And then if you have these lesions on both sides of the joint, which I mean the femur and the tibia bone, so unipolar on one side or bipolar, which means on both sides of the joint, those bipolar grafting procedures don't do as well from a longevity standpoint. And so now it's a more difficult situation. In this particular athlete situation, it was bone and cartilage, but it was also the meniscus.